Hi everyone, our group will now share more about the SLP's role in treating patients with myasthenia gravis.
As we mentioned in our last presentation, myasthenia gravis is a chronic autoimmune neuromuscular disease that occurs when the immune system attacks the body's own tissues. This causes skeletal muscle weakness. Individuals are able to perform all movements for a while, but may be unable to sustain an activity for an extended period of time due to muscle fatigue. Most individuals have motor speech difficulties, but no language disorders.
Dysphonia, dysarthria, and dysphagia are common disorders a person with myasthenia gravis will seek guidance from an SLP for. This is due to muscle fatigue and loss of control of muscles. Dysphonia occurs in about a third of all people at some point in their lives, but it occurs in 2% of people with myasthenia gravis. On the other hand, dysarthria is less common in the general public, but occurs in over 10% of people with MG. 70% of people with myasthenia gravis will have some sort of swallowing problem. MG will be diagnosed by the doctor, but the SLP will diagnose specific speech and swallowing problems. Assessment for specific speech diagnosis can include case history. This would be to learn more about the specific client and their case of MG. Non-speech examination and speech production assessments. A person with MG may seek at SLP because they perceive a change in their voice, speech production, or swallowing. Referral to an ENT may be needed to ensure that the voice issues are due to MG only.
Since flaccid dysarthria is the type of dysarthria that you will see in a client with MG, we wanted to provide a short refresher on it. From Dr. Dressler's lectures, we learned that it's caused by damage to or disorders of the lower motor neurons or the muscles themselves. In MG specifically, there isn't necessarily damage to the motor neurons, but an issue with the synaptic transmission leading to fatigue and muscle weakness, which can clearly affect speech. And as we've learned, the top three characteristics of flaccid dysarthria are hypernasality, imprecise consonants, and breathiness. Some other speech characteristics that you may notice are monopitch and loudness, nasal emission, audible inspiration, a harsh vocal quality, and short phrases. These all relate to decreased muscle strength and support, but with rest, these symptoms may actually improve depending on the client's severity of symptoms.
Dysarthria is more frequently seen in younger clients with MG. The treatment of dysarthria should occur on an individualized basis, and the SLP should plan treatment during peak medication times. The focus of treatment should be on providing compensatory strategies and environmental modifications to help increase their intelligibility. Compensatory strategies include using gestures, having either a high or low-tech AAC device on hand, writing or using email or text to communicate, and limiting long periods of verbal communication.
Treatment of dysphonia is individualized. It will be based on the severity of the voice disorder and how much improvement the client with MG wishes to make. Treatment for voice is associated with the overall treatment of MG. Medications to lessen the effects of MG often help voice problems as well. Strengthening exercises can include expiratory muscle strength training. This improves respiratory strength during phonation. Vocal function exercises are used by strengthening and coordinating laryngeal musculature and improving efficiency of the relationship among airflow, vocal fold vibration, and supraglottic treatment of phonation. Compensatory strategies could include the use of amplification. This would allow the person with MG to speak with less effort but still be heard. How to care for the voice, an example using a moderate tone to preserve energy and drinking lots of water, can be taught to the client to allow them to get the best usage out of their voice with what strength they have and what they are gaining to working on to gain.
As Corbin mentioned above, AAC is a treatment option that an SLP may focus on for clients with myasthenia gravis. It may also be used to treat dysphonia, especially as a client becomes more fatigued due to voice use or as the day progresses. Since symptoms and the severity of symptoms vary so much in MG, a clinician will need to make recommendations based on each individual case. For example, one client may present more severely and need an AAC most of the day, while others may only need AAC at nighttime or during times of distress when the muscles are more fatigued. but it's also important if the client is able to understand what the device is and how to use it. So cognition will need to be relatively intact when using this approach. But generally, people with MG don't present with many cognitive deficits, if any, so AAC is usually a good choice. And on the next slide, I'll show a few examples of types of AAC that you can actually choose from. So here are some examples of no-tech, low-tech, and high-tech choices that you could recommend. As for clients with MG, high-tech AAC may be appropriate due to their intact language and cognitive skills. However, if a client only needs an AAC for short periods of time, like during rest, when they are fatigued, for example, or during times of crisis at the hospital, then a low or mid-tech may be more suitable just due to economic reasons. If a client only needs to augment communication during crisis and chooses not to use an AAC, you may also teach them function or content words for those specific instances. For example, bathroom, water, TV, or other functional words could be used. Once again, it really all depends on the individual client.
Although it is not a motor speech issue, we thought it was important to include the way that myasthenia gravis affects swallowing. The impact of myasthenia gravis on swallowing can occur gradually or suddenly and varies from client to client. Swallowing muscles can become fatigued during a meal in as little as 1 to 20 minutes. It is recommended that a FEES assessment or examination be used to assess, as it can be used over an extended period of time and can assess laryngeal fatigue and potential progression of aspiration throughout a meal. A client's medication cycle should be considered, and the SLP should schedule the examination to be during a peak performance time. Because dysphagia may persist even if other clinical symptoms have improved, it is important for patients to have their swallowing function reassessed every 3 months, even when in a long-term remission period.
Dysphagia treatment for clients with MG is again, like all other treatment, individualized. It is based upon the underlying cause and severity of the swallowing problem. An SLP could recommend and teach the following strategies. Smaller, more frequent meals allow for the client to be successful for the duration of the meal and not get tired and not be able to finish their food. Softer, solid foods will cut down on the mastication time and preserve the client's energy. Cold foods can be used to speed up the reset of the physiological effects of MG. Advising the client with MG to take their medication, then shortly after eating their meals, can allow the effects of MG to be lessened during the meal. If the client is experiencing pain, coughing, and residue of food during the swallow, thickened liquids can allow for the client to slowly and safely use their muscles to better control the movement of the bolus. Maneuvers can be used to compensate for the muscle weakness. A chin tuck is often used with clients with MG, but there are other options.
Making adjustments to your daily life and environmental modifications are common recommendations for MG. OT and PT may play a role in these recommendations as well. These may include planning rest days weekly or scheduling events at times where the patient is the strongest. You all may recall last semester a guest speaker with MG talking about taking rest days and only teaching classes a few days a week and in the mornings only. This was an example of her knowing her limits and setting her schedule based on the severity of her diagnosis. Also, physical adjustments may need to be made in the client's home. This may include rearranging the house due to vision problems or to avoid stairs, and installing rails and other equipment to allow for resting and support. Utilizing pacing to complete tasks may help reduce fatigue as well. Stress may also worsen MG symptoms, so implementing relaxation techniques can help. And lastly, scheduling therapy sessions to best accommodate the patient will help yield more effective therapy. This may include shorter sessions of about 30 minutes once or twice a week and scheduling at a time when their strength is up, such as in the morning or at medication time. Co-treating with other therapies may also help by not overworking the patient at each therapy that they receive. And once again, this would all be based on the individual client.
Myasthenia gravis is a relatively uncommon disease that many people are unaware of. Because of this, it is incredibly important that individuals with MG are able to advocate for themselves. One of our jobs as an SLP is to provide our clients with tips on how to advocate for themselves, especially when they are traveling or by themselves. Individuals can carry a list of medications that may worsen MG or their symptoms. By keeping medication on themselves at all times, they can ensure that they do not get separated from it. Wearing a medical alert ID bracelet or carrying an alert card allows others to easily identify their disease, especially if they are experiencing a crisis.
With treatment, most individuals with myasthenia gravis can significantly improve their muscle weakness and other symptoms and lead a normal or nearly normal life. Improvement in prognosis is often related to the overall treatment of the myasthenia gravis disease.